We're back with another Myeloma Minutes podcast. I'm here with my co-host, Sally. Sally, great to see you. How are you doing this evening?
Good, thanks, Jam. I'm going to carry on with the weather theme of our last pod. I hope everybody enjoyed that. Here we are, late evening, a typical British summer. It's raining outside, but otherwise I am good, thank you. But I'm really looking forward to today's podcast because we've got a very special guest.
We're delighted to have Alex Scott with us today. So Alex is one of our wonderful specialist nurses in the transplant team in Oxford, and she is an absolutely crucial cog in the whole journey of our patients as they go through autologous stem cell transplant. And she does this for not only myeloma, but also lymphoma and sometimes other conditions as well. Alex, welcome to the Myeloma Minutes podcast. I only had to ask you 48 times if you were willing to come on. And on the 48th time, you said yes. So
Yay.
Thank you so much. I think I literally walked past her in the corridor. It's like, he's going to ask me again to come onto the podcast. Can I just walk in the other direction, take a lift? But we pinned you down eventually. Alex, thank you so much.
No, thank you for having me on the podcast.
Can you tell our listeners a little bit about yourself, your role that you do now, and how you've got to this point?
So I've always been a nurse in Oxford. I trained at Brookes, and then I did 2 years on the oncology ward, so dealing with solid tumours. And I've then done 2 years on the haematology inpatient ward, often actually nursing people through their transplants. There was this thing called the pandemic that happened, and I did my master's in the year of the pandemic, not planned. And then I joined the bone marrow transplant team, which is where I've been for the last 4 years, looking after, as you said, autologous stem cell transplants.
The main focus of the pod is going to be the really important discussion that you have with our patients as they are on the cusp of being admitted for their stem cell transplant. But you have a much broader role than that. You start the journey with the patients around the time that they are thinking about having their stem cells mobilized. There's a huge amount of coordination work that you do with other members of your team, so brilliantly. But I think the journey that we've completed over the last few weeks on the podcast, we've done the doctory transplant discussion. This discussion that you have, you sit down with the patient. Broadly speaking, when do you do it in time, in sort of relation to the timing of when people come in? And broadly, what is the purpose of this sort of consultation discussion?
So in Oxford, our role starts when we get the referral, which is often at the second cycle of the induction chemotherapy. And we touch base at that point. Our role starts right at the beginning. It goes all the way through the collection of stem cells, which has already been kind of discussed, and through those workup tests of checking the heart and the lungs and making sure that as a patient you're as well as possible. And then once you've collected your stem cells, we at that point really touch base and say, we're looking at the next stage, and actually up until this point, people haven't really had chance to talk about the transplant because with myeloma, the treatment happens so quickly. So you have 4 cycles, then you have your break, then you're collecting your stem cells, you have your tests, and then suddenly the actual transplant can feel a little bit like a black hole. And so that's when probably our main bit of contact with patients come in to play at that point.
So you first reach out to somebody when they've basically had maybe even just 4 weeks worth of treatment. I mean, how do you broach that subject and how do people respond to that? Do you think that it's easy to take in at that point in time, or is it just hugely variable and dependent upon the individuals?
I think it's massively dependent on patients, but it does give us that chance to have a bit more of a relationship with patients. We don't necessarily have a lot of contact with them at that point because we will defer to our myeloma specialist nurses, but it means that we can talk to those patients that are particularly anxious and they then don't feel like there's all this information coming at quite a late point. And also because you have that gap of about 4 weeks where you're not having treatment, often patients will say, I feel like you've abandoned me, because they're very used to coming in on those Fridays or that every week. And they're going, hang on a minute, no one's going to look at me for 4 weeks. And we say, that's all very planned. Do not worry. We haven't forgotten about you. So it does help us later down the line, I think.
What a really useful service. I mean, I suspect that practices might differ elsewhere, but it's incredibly useful to find that that's what works best for you guys in Oxford in terms of building that relationship so that you're gradually preparing people for the transplant that might be ahead of them.
Yeah, and I think what is difficult actually for you and your team, Alex, is, Oxford is a transplant centre, so the patients that are Oxford patients and they start with us, we start talking about the transplant relatively early because the place where they were diagnosed and treated is the place where they had their transplant. But we take people from all around sort of our geographical region, and sometimes you don't hear anything about the transplant. It's like, we don't do that here. You're going to hear about that in Oxford. And you're the first person, right, who is there then fending all these questions about a stem cell transplant.
We have an introductory appointment that our consultants lead, which gives them the basic outline of the transplant, which I know you've discussed already in the podcasts. But that's a lot of information for patients. So then we tend to call about a week later, if we're not at that appointment, to give them our details and to also just say to them, how are you feeling? Let's now look at that information and spread it out across more of a time frame. And then once they've collected stem cells, we then sit down and do what's called a workup chat. And we try and do it here in Oxford before they see the consultants. And the reason for that is that appointment is quite a lot of information that has to be put on a consent form, whereas we can put it into a little bit of real world. This is what we're expecting. This is what we're going to do to stop anything, to minimize those risks, and also just to let patients be a bit more aware of day to day what's going to happen and the practicalities, things to bring into hospital. We've got a list for them, and it means that they can then have a bit of ownership on what they're doing, which I think it does help those patients so that when they meet the consultant, they've got questions. They know what's happening. They've got an overview of it.
You give us a massive helping hand in terms of just making, Jam and I, when we're in clinic, things a little bit smoother by the sounds of it, but also so the patients who then come and see us are armed with the questions which are most important to them, and also kind of filling in the gaps, the things that we would forget about, which through your experience are so important to everyone going through this process, but perhaps isn't quite on the radar for Jam and I in the same way. Do you think that's a fair point, a fair comment?
I think it is, absolutely. And I think it definitely supports families as well, because there are questions that they'll ask me that they definitely wouldn't bring up in a consultation. Visiting is vitally important. It's one of almost the first things we speak about, because people do have an idea that actually when their loved ones are in hospital, they're going to be kind of sealed off in a little room. No one's going to go near them. Hazmats are out and everything else. And we say, well, actually, that's not the case. Your loved one needs family around you. So absolutely, it's great to visit as much as you can. It kind of deals with some of the practicalities that wouldn't be asked otherwise. And it puts the transplant into more of a day-by-day event. And we do talk about the risks, which means that often patients are thinking, okay, we know that that's going to come up in the consent form, and it doesn't take them by shock, which I think is quite important.
And also it's given them time to absorb that very important information, and the time between your chat with them and when we consent, I think is a very valuable few days, often a week or two, which allows them to really, I think, understand in their mind what's going to happen.
I personally really enjoy finding out from patients how much they've read, because there are fantastic resources out there. Some patients like to read absolutely everything. Other patients like to know nothing. So I do find out from them first how much have they read, because that can really help. And also find out from them, how are they feeling? They've had a hefty treatment so far. Often the actual process of collecting their cells can bring up quite a lot of emotions for them, and they've been off treatment. So often they don't really have a lot of side effects. They're actually feeling pretty well. And so to come into something where they are aware they're not going to feel so brilliant, that can bring up quite a lot of emotions. They've had chance to think about their diagnosis, which up until this point, they really haven't had that chance. Hematology moves so quickly, it does make it difficult for them. So I first of all start with kind of that. I then talk about dates. Dates are vital. We plan our lives around dates. So they need to know when they're coming in. We aim as much as we can to get people in between 4 and 6 weeks after they've collected their stem cells. They come in either via our ambulatory care or onto the ward. Part of that is fitness. Part of that is generally how they feel, and also their family setup. So they do need to be within an hour of Oxford to come through ambulatory care, and they need to be fit and well enough to do a walk or have somebody to drive them in and out. But we talk about ambulatory care as a possibility. We then count in minus days. So day -2 is admission, and that's the insertion of their PICC line, which is put in very, very well by our vascular access team here in Oxford. It goes in on the day unit, and it is a line that goes in the upper part of their arm. We have a lovely juicy vein up on our shoulder, and it goes into there. And there are great advantages of the PICC line, as you've both kind of said. We can take blood out of it. We can give products, so anything they need, anti-sickness or things like that, we can do, and it protects their vein. Unfortunately, from a haematology point of view, we're not born with the lines in. So there are always a few risks. One of them is you can get a blood clot on the line, which would mean that it would be hot and quite painful. And ultimately, we'd take that line out if we had to. You can get an infection in the line. It's not common. Haematology are very used to these lines. We deal with them a lot. So we don't get many line infections, but it is a risk. And ultimately, we'd remove that line. And the last risk is that you can kind of find that it actually blocks a bit. So we put some medicine down the line to stop that from happening, which actually works really well here in Oxford.
Great. So you give them the full sort of context about the PICC line. And I'm guessing the kinds of things people ask is like, can I walk around? Can I have a shower? Is it painful going in or coming out? And I guess the answer to both of those is no, thankfully, generally.
Speaking to some of my colleagues in other places, we're a bit unique in this, is we actually say to people, make sure you're using that arm. Actually, it's really good to put the line in your dominant arm. The more you use your arm, that line works so much better. We give you lots of anaesthetic, so it actually doesn't really hurt. You probably feel a bit of poking and prodding, but there shouldn't be anything sharp there. And it goes in really nicely. I often make the joke that our line team come in dressed as surgeons, which I always think is slightly disconcerting, but it's vital for the sterile nature of it. But actually, I reassure patients that we're going to have this in for 3 to 4 weeks. Often we don't send people home with them. The lines can stay in for a lot longer. So actually, they're only in for a little tiny portion. They do pay dividends when they're in. It's a lot nicer than those little cannulas they can have. And often our patients have had experience of that. And we say, as well, one less needle is always a benefit to them. And then we say, once you've got your PICC line in, you might feel a little bit bruised later on in the day, often paracetamol, but most of our patients don't need anything. And then if they're coming onto their inpatient ward, they'll wait for the bed to be ready. If they're going on our ambulatory care, they'll see our doctors, they'll see pharmacy, and then they'll head off back home or to the flat.
I'm going to remember so much of what you said and utilise it myself. But can you just talk us through ambulatory care versus the inpatient stay? What exactly does ambulatory care mean? And who may or may not be a good person to use that service?
Ambulatory care is a service we have here in Oxford. It's a day unit, but on a much smaller scale. The advantage of ambulatory care is that you're not an inpatient on a traditional ward for the first about week. You're always going to get 2 weeks in hospital. That's always going to happen, however you do it. But actually, it is nice to have that first week when you're feeling really well, actually, either at home or in our on-site flat. So in terms of who it's right for, you need to have good feeling in your fingers. Okay, because you may well have to press buttons. You may need to kind of do things for your medical care, just in terms of buttons and things. So you've got to have good feeling in your fingers. You've got to be able to walk fairly well. So you can absolutely need a stick or need a frame, but you've got to actually have decent walking ability. Ultimately, you also need to have somebody who can be with you if you're staying at home. So if you were to get ill overnight, you would be coming to our haematology ward, and you've got to have someone who can drive you. I say to our patients, it's a gut feeling, okay? So I've already looked at people. I've already had a little chat with my team and said, I don't think this patient is right for ambulatory care, and we might not raise it. If we raise it, I say to our patients, think of it as a gut reaction. Some people are horrified at the idea, and if they are, that's not right for you, and that's okay. But some people are really keen on it. So it's a really great provision to have. And it also means we're not waiting on beds and things in wards, which always is better.
Brilliant. Thank you so much. So you can kind of get going sooner, maybe, because like you say, you're not waiting for beds, and then the person comes in when they really need to be in, which sounds like the perfect solution, like you say, for the right person.
Yeah, so it's a way of our fittest patients in a way, with appropriate geography and people around them and ways of ensuring that if they do get unwell, they can get into hospital, keeping them out for longer, which I think absolutely improves the whole experience of the transplant. But as you say, Alex, it's not for everybody.
It's a great provision to have, and we're really lucky here in Oxford to have it, which is fantastic. So once you've had your PICC line in, you're either going into our inpatient ward or you're going back to either the flat on site or your own home, depending on geography. Then on day -1, you have your melphalan. It is a very strong drug. It goes into your system and it goes around your body, and then it leaves out of your kidneys and in your urine within 24 hours. What it's doing when it's going around your body from your PICC line is it's touching all your cells and then causing a chain reaction within that cell that leads to that cell's death. So with melphalan, you do get 2 waves of side effects. So you get the ones that are on the day, and that's mainly, unfortunately, nausea, very, very occasionally vomiting, but we don't see much of it at all. And so we have 4 anti-sicknesses that work really well together. You have ondansetron, which most of our patients have had before. Dexamethasone, nearly all of our patients have had it. That's your steroid. They've had it in huge doses. So patients are often a little bit horrified when I say we're going back onto dexamethasone. But I say, actually, be aware you've had it in big doses. This is a little tiny dose. You're only having 4 milligrams. And actually, it's really well tolerated. You don't get the side effects that you've often already experienced. And then there's 2 drugs that are new to our patients. So you have aprepitant and you also have olanzapine. Now, aprepitant and olanzapine, I always explain it as being the next rung in the ladder. So you've got ondansetron and dexamethasone, and then you've got olanzapine and aprepitant. For about 90% of our patients, those 4 drugs working together manages all of our nausea. If you're in that 10% that do feel nausea, tell us, because there's always something else we can give. There are no prizes for being a martyr. There's no prizes for not really telling us, because actually I often spin it with our patients and say, actually, you're helping us if you tell us early. You're not a burden, but tell us early, because it gives us time to try something and then say, did that work? Did it not? Otherwise, we end up giving you loads of anti-sickness. It gets rid of your nausea, which is brilliant, but we have no idea what worked. So the next time you get nausea, we have no idea what we're reaching for. So it really helps to deal with a little bit of nausea rather than waiting until it's a lot more. The same goes for pain. When you're on your melphalan, as you've both said in the previous podcasts, we do have ice lollies and ice cubes that we have in Oxford. So you get a little wine cooler bottle that comes, and you have ice cubes and rocket lollies. And the idea is you keep your mouth as cold as you possibly can. So we need it on your tongue, but also moving around your mouth to really keep your mouth as cold as you can. Now, ideally, we have 15 minutes before the melphalan, the half an hour that the melphalan is running, and 75 minutes afterwards. So all by the shouting, it's 2 hours of keeping your mouth as cold as you possibly can. It's a lot. We know it's a lot. We always say we hope for a heat wave on that day. We're very British, but often we won't have that. So we say wrap up warm, but 5 minutes is better than nothing. If you can do 5 minutes, it will pay dividends in your second week. So whatever you can do is better.
75 minutes afterwards.
75 minutes.
I wasn't aware of that. I mean, I'd need a number of different brands. I'd need Calippos. I'd need different types of rocket lollies, maybe flavoured ice, slushies.
Oh God!
I think we need to think about the lolly menu in more detail. I mean, that's phenomenal.
It is a lot.
I mean, I'm guessing not many people manage that, because that is actually very hard, and actually probably ends up being actually quite painful as well.
A lot of our patients will manage it. A lot of our patients do manage it.
They do.
The gentlemen tend to have a lot of competition. So if you have a few of them that are around about the same time, there's a lot of, I got through 40 ice lollies, and you're like, oh, good, great. So there's a bit of competition there. Lady patients, to be slightly stereotypical, do tend to just say, I just got through it. But actually in Oxford, we're one of the only centres who use this oral cryotherapy and actually provide our own ice lollies. Other centres, you have to provide your own. So there you go, Jam. You'd be able to get whatever ice cream you'd want there.
There's a little business in there somewhere, a little sort of ice cream van driving around various wards of transplant centres. But anyway,
there you go.
But no, that's really interesting. But as Sally did say when we were talking about it in the last pod, it's one of these things that most centres do now, but I think it's not completely universal. And we made it very universal, I think, about 3 years ago. Before that, it was quite patchy, actually, to be fair. But we have made it more universal. And, anecdotally anyway, with melphalan, we see very little higher oral mucositis now, like genuinely very, very little. Like it's made a big difference.
We're not seeing the mouth ulcers that we were seeing before.
Yeah.
We're not seeing that amount of really struggling to swallow your own saliva that we've seen in previous years. So it has been absolutely groundbreaking for us. And we have seen huge impact from it. And then after your melphalan, you will have quite a lot of fluid, which just really helps your kidneys just really flush out that melphalan. It is really important to keep drinking. We will keep providing you with water just to make sure you're flushing out those kidneys really well. You then either go back to your flat, home, or you're on the ward. Typical is that the next day is the return of your stem cells, which is your day 0. Sometimes you might have an extra day just to help your kidneys wash that out fully. Because what we want to make sure is that all of the melphalan is out before we put in your very precious stem cells. Now, your stem cells that were frozen, they were put into different bags. So you had them collected in one bag that you saw. When we froze them down, they were put into different bags. And your consultant will decide exactly how many bags you're going to have. We will tell you how many bags you're having. And typically, it's only one day of giving your cells back. It's a lot quicker to give them back than it is to take them. Sometimes, if you have got a lot of bags, we might put them over 2 days just to stop any nausea really happening, because there's a preservative in there that can cause a bit of nausea. But what will happen on your day 0? You do get your second birthday, so you get to join the royal family only on birthdays. We're not promising anything else, but you get this cell return. Now, your cells will come in a big shipper. Think R2D2, but without the skis on the bottom. And that's a big shipper that will come in, and that's filled with liquid nitrogen and your bags of cells. You'll have your fluid in the morning, and then normally about lunchtime, we start giving you your cells back. So what will happen is we'll ask your name and date of birth more times than you've ever been asked before. So by the end of your cells, you'll really know that. So that'll be okay. We don't mean to be rude, but I give cells, and I know I sort of am rude. There's myself as a nurse and a physician's associate in Oxford, or in our other centres, it might be another nurse, who then basically read a load of codes to each other. And that makes sure that the cells match my paperwork, matches the patient. We then spin round like we haven't just been being rude, and we say, "Are you ready?" And patients go, "Yeah, sure, it's fine." And those cells come into our water bath that then defrosts them, and then it goes in via your PICC line. For the most part, you just sort of sit there. It's 10 to 15 minutes per bag, and we get them in as fast as we possibly can. The defrosting will take about 3 to 5 minutes of actually being in the water, and we're watching for those ice crystals to go. As soon as that last ice crystal is gone, the physician's associate or nurse will take that out of the water, give it a clean with alcohol externally, and then hand it to the nurse, and the nurse will then hang it and attach to your PICC line. Once it's attached to your line, it's 15 minutes or as quick as we can. So often it's a lot less than that. And we'll make sure that those cells go in nicely. The nurse that's giving them will be constantly asking you, "How are you feeling? Are you feeling okay?" And a lot of our patients feel very like it's a huge anticlimax. They've waited so long for these transplants. They know it's not a surgery, but they kind of go, "Is that it? Is that all I was waiting for?" And you go, yeah, that was it. But that's okay. We like anticlimaxes. It means everything's gone very smoothly.
So, Alex, a really quick question. It's so interesting to hear you say this. This is generally going through my mind. So if you're waiting for those ice crystals to defrost, when it goes in, is it not a tiny bit chilly? And also, really obvious question here, but what does a bag actually look like? What colour is it? I mean, just, what can you see there? Are you checking it? It's just, we're not really part of this process. So, I'd welcome that knowledge, please.
So we warm them slightly so that it's not cold, because you don't want the vein to kind of go too cold. However, it's a balancing act, because the preservative that's in there will keep working even when it's hung up. So if you leave it for too long in the water and you heat it too much, those cells will clump. So it's a balancing act. You don't want to heat them too much, and then it's going to be harder for the nurse to infuse those, but you don't want it to be too cold for the patient. It's normally about 100 mils in there, and it's often a straw colour. When you've collected your cells and you've had your harvest, you can look at the big bag and it will probably look very kind of like a sunshine yellow colour. And actually it's probably a bit darker when we defrost, and that's because we've mixed that preservative in. And you've got a bit of plasma in there as well, just to make sure those cells are really nice. Now, whilst patients are sat there, we do say visitors can be there if they want to. And what will happen is they just go back to back in those bags. Now, very occasionally, you can get a bit of a reaction, and that's to that preservative. So you can get a little bit short of breath. You can get a bit itchy. You can get a bit scratchy. You can get a few reactions to it. Now, we do give medicine to stop that before we give the cells, and that's paracetamol, hydrocortisone, and chlorphenamine, so Piriton, essentially. And that really just settles our body down so that we're not going to react. Now, if you've ever reacted to a drug before, often everyone stops, we disconnect that drug, and it's all a lot of action. When you have your cells, we know that once those cells are inside you, you'll stop reacting. So actually, we kind of just say, let's just get on with it. Let's not kind of prolong this. We know you're safe. We are here to look after you, but let's get these cells in. But I do say it's very rare you get a reaction. Very rare indeed. And afterwards, as well as feeling very, very tired, because Piriton does make you quite sleepy, you often get quite a lot of emotions because it is that day of you've been building up to this, and it's almost oh, I've done it now. And it can be a little bit of kind of a emotional day, and it can be a bit almost disappointing. And so we do tell people about that just so that they're aware, and so family can kind of come around that patient and say, hey, we expected this. This is okay.
I want to come back and refer back to our previous podcast and the other food chat that we had, and the whole sweet corn sort of smell that we spoke about. Where are you with that? Can you smell it, and do you think it smells the same? And also, when does that start to happen?
Do you like sweet corn? I thought you were asking about, like, do you like sweet corn? Or what are your other vegetable preferences?
Yeah, I do like a bit of sweet corn. I now can't smell the cells at all. Possibly if I've just been on annual leave, I'll get a little whiff of them, but I'm around them so much, I don't really smell them. I do warn families and say to them, be aware that your loved one is probably going to say they stink. You're going to say they stink. And they're not actually being horrible. It's just they can smell that sweet corn. The patient can't. So yes, it's interesting, the wider team, as they walk down the corridor, they can always tell you which room the cells have been in because of that very well-known smell now. And once they've had their cells, you've got about 3 days of feeling absolutely fine. So up until day +3, so 3 days after your stem cells have been given, you're feeling absolutely fine. Progressively, as you get through that, you're starting to just feel a bit more tired and a bit kind of, I can't really be bothered to do anything. It is really important that you keep pushing through and doing things and getting up, washed, dressed and ready. And then day +4, day +5, that's when that second wave of those Melphalan side effects really start to show themselves. It really always starts with you just feeling really thirsty. So you'll wake up and you think, I'm completely parched. I really need a drink. And you'll have a big drink, and 10, 15 minutes later, you're going, I'm really, really thirsty. That's the start of things. Now, I tend to say to my patients, I go top to bottom in side effects. You'll get a bit of all of these. What we don't know is which is going to affect you the most, okay? Hair will fall out. So your hair and any facial hair does fall out during the transplant. It happens a bit later. It's on to kind of the end of the second week that hair starts to have those changes. But I talk about it now so I don't forget more than anything. We do say to our gentlemen, please don't wet shave, because if they nick themselves, it's an impressive amount of blood. And often, a couple of days of not shaving and your hair will be falling out anyway. So it'll be okay. You do get dry mouth, very occasionally sore mouth. It's not too bad. Dry throat, sore throat. A feeling of, if you've got a sore throat, you can swallow, but you've almost got to work a bit harder to swallow. And you can sometimes get kind of a shoot of almost electricity pain with that swallow. You can get heartburn, indigestion, appetite completely goes, and your taste really changes. Food that isn't lumpy can feel lumpy. So a yogurt, which is normally a very smooth feeling, can feel like it's more lumpy and hard to eat. You can get a feeling of rolling in your tummy, nausea, very occasionally vomiting. We don't get a huge amount of it, but there is that as a risk. And from your belly button to the top part of your pelvis, that real bottom part of your abdomen, you can get some quite intense cramping sensation. Unfortunately, diarrhea. And we're very British, we don't like to talk about poo. I talk about it quite a lot in my job, so I'm a little bit immune to that. But we do say everyone's going to get diarrhea. It's not pleasant, but please tell the nurses, because what we'll do at that point is we'll take a sample to check there's not a bug in there. As soon as we know that there's no bug in that diarrhea, we can give you medicine to stop it, which is loperamide or Imodium. And it works very, very well. The thing to remember, especially with the diarrhea, is that your bowel, all the way from your mouth, all the way down to your back passage, is going to be pillar box red. Subconsciously, all of us will think, if I don't eat, if I don't drink, I won't have diarrhea. Unfortunately, that is not true. And we just have to manage that situation. In other things to be aware of, so this week too, we're very reactive to what the patient's showing at that time. So if they're in pain, we'll manage the pain. If they feel sick, we'll manage it. One of our key teams that will also help us with our symptom management is called the Hospital Palliative Care Team. Palliative care is associated with death and dying. That is not the case with the transplant. They are experts in managing symptoms. And so if we do have a situation where someone's really feeling nauseous or they're in pain, we may bring them in just to give us a bit of advice. I warn people more for their family's benefit because it's normally a bit of a perfect storm. Patient's not feeling so great, so they're not reactive on their phone so much. So then families come and visit, they walk onto the ward as the hospital palliative care team are leaving their loved one's room. And it can cause quite a lot of emotions. So we do just let people know about that. During the second week, our PICC line will be used quite a lot to give any medicines that we need. The other thing that we do need to talk about is food, which I know you have raised in podcasts before. As we sit here now, we have a basic amount that our body needs for us to do the work it needs to do. My appetite far exceeds the calories that I need for my body to work. So it's fine. But in a transplant, you're looking at needing so many more calories to repair and let your body recover from that melphalan that we've given. Your body's running a marathon, so we've got to fuel it for that, despite the fact you don't feel hungry, nothing really tastes right, and you've got a bit of nausea. So we do have our dietitians that really help us with that, and it is often a case of we have to eat for the sake of eating. Your food is another medicine that we will give you alongside everything else.
Alex, when you talk about food, I'm guessing one of the first things people say is that I just can't cope with hospital food. It actually makes all those symptoms that you've just been talking about much worse. How do you counsel people about bringing snacks and food in, or people cooking food at home, or if they don't just feel like eating for a couple of days? Is that a big deal? Because talking about nutrition and food is something that comes up a lot during the transplant, isn't it?
It is. And it's because you have no hunger. So I tend to say to patients, we are a little bit the reverse Weight Watchers. So we need raw calories into you. So if you know you can always eat jelly babies, bring in jelly babies. That would be great because you'll think, I'll just have a couple. We're less concerned about, in that second week, having set meals. We almost really want a bit of grazing and a bit of not thinking about food as a burden, because that takes a lot of time to overcome that. So we really want to support people into eating as they can without making it a huge mental battle for them.
And it's funny because almost sometimes when I'm doing the round for people on transplants, I was rounding today, and Sally, I don't know if you feel the same, almost with the myeloma transplants, if you've seen what people have had for breakfast on a certain day, in a way that gives you a lot of confidence of how they are. So it's like day 10 or day 9, you've eaten 2 pieces of toast, and toast is not always the easiest thing to kind of, it's quite dry and actually get it in. It kind of almost gives you clues that actually they're fine. So it's one of those things that I think gives you a lot of information, actually.
Yeah, I mean, I completely agree. I think so often when we're doing the ward rounds and we're looking after the patients whilst they're in hospital, similar to you guys, Alex, and the nurses on the ward, we ask a lot of questions about, have you eaten today? Are you drinking enough? Have you been to the loo? What's your poo look like? Are they grading on the Bristol stool chart? You know, we'll do a whole podcast on poo if there's an appetite for it. But yeah, so I mean, it is actually incredibly important. And these questions aren't just for the sake of it. And because we have an obsession with certain parts of the bowel, it does actually tell us an awful lot about how someone's faring, doesn't it?
Yeah, absolutely. Home cooked food. We all prefer the food that we have at home to a hospital. Home cooked food is absolutely fine, but there are things that we need to be aware of with it. So we don't want rice being reheated. And it is those real basic things that we've done for so long when we've had a loved one on treatment. It is a little bit second nature, but it's just making sure that that food is nice and piping hot and stored correctly.
In terms of I mean, this is a huge other area. So I understand that we've got a limited amount of time. The neutropenic diet and the fact that you may talk patients through what they perhaps should or shouldn't be having whilst they're in hospital as well. Could you just quickly summarise that for us, perhaps?
So I tend to say very much to patients, make sure that your hot food is hot, cold food is cold. The best before and expiry dates really do matter. You're not having your soft cheeses. You're not having anything that's raw. So everything needs to be cooked really nicely and really kind of fully. Don't have any steaks that are slightly rare. It is part that gets a little bit of a giggle. Where do people get their eggs from? If you have Red Lion egg from the supermarket, you can have runny eggs. If you don't and you get them from a farm, we do say they do need to be hard-boiled.
But just to recap, the logic behind that is then if your food isn't heated properly or food that should be cold gets a bit warm, there might be some bugs within that food that if you then swallow them, they go into your tummy, could just make the situation a little bit worse. Is that how you understand it?
Essentially, yes. Guts are full of bugs. We have a full zoo in our body, which our immune system is sitting on top of. Now, this is the other part of week 2, is that immune system goes. So we have to be aware of all those bugs, not just, a bad bug, a naturally kind of good bug is also a bug. And our immune system sits on top of those. And in week 2, when this immune system goes, one of these bugs that are in our gut are going to spike up because there's nothing stopping them. And they're going to reproduce and they're going to get more. And what happens and what all of us are going to be watching out for is for a temperature. It's not the only sign of infection, but it is kind of one of the main ones. And at that point, often we will be walking around the ward and saying, oh, you'll get a temperature today, or we think you'll get a temperature today. What happens when that temperature happens is we will take some blood out of the PICC line. We'll take some blood out of a vein as well. We'll take a urine sample. We'll take a stool sample if you've still got diarrhea. And we'll take a swab of your throat. And what that is to isolate what bugs are there. Now, for the majority of our patients, we won't find a bug because the tests that we do don't show the bugs that are naturally in us. Because otherwise, all of our tests would be positive because we've all got these bugs. And you start on a really strong antibiotic. What that does, and the aim of it, is to come in and be a temporary hat on these bugs. Often, 24, 48 hours later, there's another part of your blood that looks at infection, and that level is nicely falling. Some people don't have that level falling, and we might need to switch to another antibiotic. Again, that's very normal, and 24, 48 hours later, that level in your blood that's looking at infection is coming down nicely. With that, patients are feeling better. Now, I do kind of preface this next bit with, remember we're doing this to put your myeloma in the best position so you get the longest time without having to have lots of different treatments. This is kind of the bad and the ugly side of transplant. And it's the risks that we know are there. We talk you through real world kind of how this happens, but it's remembering that these risks are small. So for those patients that have had 2 rounds of antibiotics and this still isn't managing their infection, they've often still got diarrhea. So we're losing a lot of fluid. So we're sweating, we've got diarrhea, generally just everything's working very, very hard, a decision is made by the whole team that the ward is no longer the safest place for this patient. And that's when we go to intensive care. Our intensive care ranges from literally giving a drug that we can't give on the ward, and you might stay in intensive care for 24 hours, all the way up to multiple organs being supported by machines, and that patient being put to sleep to let their body recover. That risk is little, okay? So here in Oxford, we have a less than 10% risk of going to intensive care. That means a more than 90% risk, or, that you won't be going. The provision is there should we need it. The other risk is for those patients that have gone to intensive care and are finding that no matter what we do in terms of antibiotics and things, we can't get on top of that infection. And that's where a risk of death happens from the transplant. Now, again, that is a really small risk, and the exact percentages would be given more by the consultants, but we say it's a less than 5% chance, more than 95% chance that you're going to be okay. So it's really important looking at those figures kind of both ways, because they are scary.
So Alex, I mean, those figures may have been mentioned in passing by consultants as they've talked about stem cell mobilization and other aspects of the process of getting to the transplant. But to be fair, not always. It is, of course, in the literature, but as you say, some people won't have read it, and you may be the first person who really goes into what you've just said so eloquently about intensive care and death. So in all the years you've been doing this, how do people react, or is it just incredibly variable from complete sort of shock or disbelief to like, yeah, no, I get that and I just have to roll with it? What sort of things have you seen?
For the most part, it is a lot of shock because we're putting a figure on that. And we're also saying it very clearly about these are the risks. Patients will often say, I knew that there was a risk, but I don't like to think of it. And that's one of the reasons that's quite nice, the way that we're able to talk to patients first, is that we can give that space where in a consultation where you're doing a consent form, it's written there in black and white, risk of death. So it's actually nicer just to talk to people first and say, actually, this is what we're expecting. This is how we're going to minimize those risks as much as we can. Often as well, we will also bring in just making sure that wills or any paperwork have been done. And often I do say, we are not expecting things to happen. We are not expecting you to need this, but it's important that this is managed so that your loved ones will also know what you want out of this. We always give a little bit of space to let that breathe and to actually say, how are you feeling with that? There's often quite a lot of emotion. There's often quite a lot of tears, but I think it plays it very openly. And I do say to people, I've raised this. So now if you need to talk about it, you're not trying to get that into a breakfast conversation because it doesn't happen. But actually you can say, well, Alex said, and then I'm almost the bad guy in it, which is absolutely fine by me. We then spin it and we say, well, actually, why would we be in the earlier group and why would we only expect one antibiotic when there is this huge other risk? And we do say, well, actually, it's about how people have managed their treatment before. Little bit basically, we say that it's about if you've had lots and lots of antibiotics, those bugs in your gut know how to move around to that antibiotic. A lot of our patients are very lucky and haven't had to have lots of antibiotics. So when that antibiotic comes in, the very strong one in the transplant, it will be that hat rather than becoming almost a cat and mouse game where these bugs just know how to get around it and reproduce. And then we can say, go back to week 2. You've had these horrible side effects. And then we'll actually look at how things change in week 3 and how things get better.
You get the raw emotion, and I've just thinking out of the hundreds of patients I have consented for a transplant, I haven't had tears once during the consent process. And I think that's because you and your colleagues take a lot of that raw emotion through this discussion that you're having. And these are difficult things to talk about, but they're so important. Like, have you done your will? Are your affairs in order? I mean, it's absolutely crucial. And thank you for spending some time talking about them. It's really important.
It gives people that opportunity to raise it, because often families have said to us, well, actually, I don't want to ask about the will because that's almost putting a negative spin on it. We just try and say, well, actually, we should all have wills in place. We should all have things there. And actually, this is quite a good point to just check those things and see if things have changed and need slightly updating as well. As we then come into our third week, what will happen is our patients will wake up one morning and they'll go, I feel different. I don't feel bad. I don't feel ill. I feel different. And the doctors come in and they tend to say, you have counts. And patients go, what's that then? And we say, those neutrophils that start really, really high in the first week, drop and spend the majority of second week on the floor and not there, have just started to show themselves. We're talking 0.02 of a neutrophil. It's a great day. Everyone has a fantastic day because they can see that things are getting better. In themselves, it's extraordinary how little neutrophils we need to feel better in ourselves. Neutrophils are vital. And actually, over the next few days, patients will steadily rise. Then what tends to happen is patients are feeling very, very good. And they're feeling like, okay, I'm starting to feel better. Still very fatigued. Still feeling quite delicate. But actually, comparative to how they felt the week before, they feel much better. And nearly always, patients will find one morning, the doctors walk in and they say, what are my counts today? And the doctors are like, 0. And at that point, the novelty of being in hospital has well and truly worn off. Patients find that so difficult because it's that I'm never leaving, I'm changing my home address to the hospital, everything's happening. And that's when myself and my colleagues often get a phone call saying, it's been a disaster. And we say, oh, okay, hold your nerve. Your cells will come back. It's that kind of divide of an hour difference in the blood being taken, going onto a different machine. We are looking at such tiny amounts of cells. It might not be visible and we might lose them, but actually the next day they're back up again. So just hold your nerve, which is a lot to do with that third week. And kind of comparative to that, there is a bit of a NHS line that is, we plan your discharge before you're ever admitted. We think about that as we come into week 3, particularly because you're starting to show that signs are getting better. Now, here in Oxford, we say with neutrophils of 0.5 and above, you can go home. If we forget that you're you for a moment. Now, often neutrophils are very pesky and they tend to stop at 0.48 neutrophils. And patients say, are we really going to split it over this tiny amount? And I say to patients, well, yeah, we are, because actually you've got at 0.5 a quarter of the minimum amount that everyone else is walking about with. So we are attached to that 0.5 for good reason. It is difficult when patients have said, I've had a week with no neutrophils at all, and we're worried about such little amount. But it is vital because they can come up and down in that period. Taking away from just the bloods, we will look at everything else because we're more than just a set of blood results. Each patient needs to be eating, drinking. If we've had, I know in previous podcasts we've spoken about nasogastric tubes or those NG tubes. If they've had to be in and they're really not common, they've got to be out. They're not your new fashion statement. They need to go. You need to be eating through your mouth. You need to be off antibiotics or on a tablet antibiotic. So no IVs through that PICC line. You've got to be able to walk about. We're not asking your loved ones and families to turn into carers at home. Absolutely, a family are likely to do a bit more than they did before, but actually it's really important for patients to be doing bits and pieces themselves. When we get to this point in the actual transplant, we do what's called another chat and we do what's called discharge chat. And that discharge chat is really what to watch out for when you go home. And we give you 10 key points. But actually at this workup, we just sort of say, it's going to happen. And we give a vague kind of roadmap because of the amount of information we've already given anymore, and people don't really know which way's up. So we do just spread that out a little bit. On discharge, we do tell people that you will be coming up until 28 days after your cells have been in to your local hospital twice a week. And that's often for a blood test and for any transfusions that you might need. Often you are going to have a couple of units of blood and maybe a couple of units of platelets. Very normal. Doesn't really matter if you have more or less, but as a standard, a couple of both is fairly where we're up to. And you'll also have electrolytes as well. Some of the medicines you're on will drop your magnesium. You need a certain amount of it, so you may well have a drip of magnesium or something similar. We have another full month at home, each day getting better, feeling stronger, being more yourself. And you really do see that sharp increase of ability and just feeling a lot better and being able to do things. And you will have possibly a bone marrow biopsy. I know they're not people's favourite, but they are really important diagnostically for where we're up to. And then from a transplant point of view, we do a hop, skip and a leap to 6 months post-transplant, where on discharge, we've asked patients, GPs, to give them vaccinations. Now, we don't test to see whether you've got those antibodies, but it's really important that we do have those there. So a vaccination isn't going to do you any harm if you already have some. So we can't prove you lose all your antibodies, but we also can't prove we keep them. So just to be on the safe side, we do offer vaccinations at the 6-month point. That is a whistle-stop tour of transplant.
It's wonderful to hear you talk through it. I have a real impression now. I feel a little bit closer to the patient's perspective. I mean that sincerely. And if you don't mind me sharing, I think the way you explained that was really, really informative and helpful. So thank you. Do you have any top tips for people who are about to embark on this that you've, that through all your experience over the years, you think, I really do need to share that, or that's a really handy thing to know or to understand?
Technology is absolutely your friend. Your first week, you're going to be bored. So bring in your computers, tablets, anything like that to keep you there. It's also a great lifeline for those community feelings of having FaceTime and things. It really does help. You can FaceTime over dinner and you can have dinner with your family, which often takes the pressure away from eating. If we're a bit distracted, we do tend to go food to mouth a lot easier. So technology is absolutely vital. Keep going. So each day, just set yourself a target of, I'm going to get washed, I'm going to get dressed, I'm going to sit in the chair. That's 10 minutes of your day. In the thick of week 2, that's an entire day, a couple of hours to prep yourself for a shower, half an hour standing in the shower going, why am I here? Oh yeah, I was having a shower. And then that recovery time afterwards. But it pays dividends then when you're going home. You haven't lost as much muscle and things, but keep going, keep eating, and distract yourself as much as you can.
So I normally see patients about a week after Alex has done the talk, the workup chat. So I will often say, you saw Alex last week. Oh, do you have any other questions? Like, no, Alex went through absolutely everything brilliantly. As you can hear, listeners, this is an amazing resource, Alex. I think you do a huge service to our patients, and I hope this pod as a resource people will find useful, because it's still a standard treatment, the transplant. We're going to be delving over the next few months into questions like, well, when will we be able potentially not to do transplants? But certainly for the foreseeable future, it's in, and it continues to happen all over the world. And I think understanding that journey, Alex, that you've so sort of eloquently described, fills people with confidence. And yeah, I mean, the side effects can be really bad, but understanding it's like, oh, it's day 7. This is supposed to be happening. It's rubbish and I feel like crap, but I'm not scared because it's supposed to be happening and we can get through it. And as you say, you and other colleagues will also, come down during the transplant as well, just to sort of ensure that things are going as they should. And, that all important discharge chat as well, because sometimes people say, right, I'm going home. And then you get home, it's like, oh, this is still going to take some time. But as you said, and as we said on the last pod, people get back to normal. Thank you for sharing your insight and experience with us this evening. I'm glad I only had to ask you 48 times to come on the pod. And now, rather than talking to patients, you can just put the podcast on, you just press play and put your feet up. And from me and Sally, we'll see you at the next pod.